Assalamu alaikum. Good morning, everyone. My name is Dr. Srizan Karel, and my moderator is Dr. Abbas Jafri, and I'll be presenting on topic management of non-seminomatous testicular cancer in today's class. So the objectives of my presentation is first the introduction, staging of non-seminomatous testicular tumor and the treatment on the basis of different staging. First of all, Zom cell tumor accounts for 95% of the testicular cancer, which may consist of one predominant histological pattern or a mixture of multiple types. Non-seminomatous germ cell tumor is quite common, and peak incidence is between 15 to 35 years. And in most series, the ratio of seminoma to non-seminomatous germ cell tumor is approximately 1. So what are the differences between seminomas and non-seminomatous germ cell tumors? So they differ in clinical and biological behavior. Seminomas are most likely to present with localized disease compared to non-seminomatous germ cell tumor. Seminomas display relatively indolent growth, a long natural history, and rarely spread via bloodstream beyond the retroperitoneal lymph nodes to other areas such as liver, lungs, bones, or brain, which is more common in case of non-seminomatous germ cell tumor. And stage 3 metastasis occur more frequently in men with non-seminomatous germ cell tumor. Now, beta-HCG and alpha fetoproteins are elevated in majority of men with non-seminomatous germ cell tumor. And if serum alpha fetoprotein is seen in cases of seminoma, then they are considered mixed germ cell tumor. And these cancers are regarded and treated as non-seminomatous germ cell tumor. The seminomas are exquisitely sensitive to radiation therapy, while non-seminomatous germ cell tumor are more radio resistant. So non-seminomatous germ cell tumor are variable compared to seminomas in their appearance and prognosis. The four main types are embryonal carcinoma, which is present in about 40% of the cases, and they are rapidly growing and aggressive tumor, and secrete HCG and alpha fetoprotein both. Yolk sac carcinoma is more common in children, and they respond quite well to chemotherapy, and they secrete alpha fetoprotein. Choriocarcinoma is rare but aggressive tumor, and again it secretes beta HCG. Teratoma can be both benign and malignant, and they are mostly radio and chemo resistant, so surgery is the mainstay of treatment for teratoma. Now, prognostic stage grouping for testicular cancer. This is very important to know the management of non-seminomatous germ cell tumor, and this was quite well explained by Dr. Jamal in previous class. Just a simple form is stage 1, disease is localized to the testis. Stage 2, they spread to the retroperitoneal lymph nodes and no other lymph nodes are involved. In stage 3, the disease has metastasized to other lymph nodes beside retroperitoneal lymph nodes or distant organs such as lungs, liver, bone, and brain. Now, beside these staging, stage 1, 2, and 3, in all these stages, we are also supposed to look the serum tumor markers. Now, in stage 1, there is no elevation of tumor marker, that it is S0 level. In stage 2, it is either elevated or mildly, it's not elevated or mildly elevated, that is S0 or S1 level. And in stage 3, S2 or S3 level may be present, or even S0 or S1 if there is distant metastasis. So stage 1 disease. They have high risk of relapse if they are if we do not go for adjuvant treatment following orchiectomy. The risk factors used for predicting the recurrence following orchiectomy for clinical stage 1 disease includes lymphovascular invasion, predominance of embryonal component in primary tumor, and pathological tumor stage T3 and T4 disease. If none of the above mentioned risk factors are present, then they are considered low risk and the relapse is only 10 to 14%. But if any of these risk factors are present, mentioned risk factors are present, then they are considered high risk. Now, depending on which risk factor are present, now relapse rates are different. Now, tumors with predominance of embryonal carcinoma alone with no lymphovascular invasion has relapse rate of 20 to 40%. If tumors demonstrating lymphovascular invasion alone has relapse rate of 40 to 55%. And with the predominance of both embryonal carcinoma component and lymphovascular invasion, relapse rates are more than 50%. So mainstay of treatment in stage 1 tumor includes surveillance, adjuvant chemotherapy, and retroperitoneal lymph node dissection in some cases. Now, each approach is associated with 99% of long-term disease-specific survival. A sperm banking option can also be provided to those individuals who are concerned with fertility preservation prior to treatment with retroperitoneal lymph node dissection or chemotherapy. Now, EU guidelines recommendations for treatment of stage 1 non-seminomatous germ cell tumor includes. Now, first of all, we need to inform the patient about all the management option following orchiectomy, surveillance, chemotherapy, and retroperitoneal lymph node dissection, including the treatment-specific recurrence rate as well as acute and long-term side effects. If surveillance is offered, risk-adapted treatment based on lymphovascular invasion or embryonal carcinoma component present or not. Discuss one course of cisplatin, etoposide, bleomycin, BEP as an adjuvant treatment alternative in patient with stage 1 non-seminomatous germ cell tumor if the patients are not willing to undergo or comply with surveillance. Now again, the approach to the management depends upon the presence of high risk group or low risk group, that is likelihood of relapse, the relative importance of the risk of relapse and of the different toxicities for an individual patient, the ability of the patient to adhere to post-treatment surveillance. Now, importance of multidisciplinary approach was also illustrated in a Dutch study that included almost 1,300 men with clinical stage 1 non-seminomatous germ cell tumor. There were about 1,300 patients, and the cohort, the study was of 5 years duration. The relapse rate was seen in 30% of the cases. The median time to relapse was 5 months, and despite this, the mortality rate was less than 1%. Of 356 patients underwent chemotherapy, out of which 98 underwent post-chemotherapy resection of residual masses. Only 8% underwent chemotherapy followed by surgery. Now, low-risk disease. Either surveillance or adjuvant chemotherapy should be the option in this case. For stage 1A, low-risk disease, offer surveillance if the patient is willing to and able to comply, or adjuvant chemotherapy with one course of BEP if the low-risk patient are not willing to undergo surveillance. For high-risk disease, beside chemotherapy and active surveillance, RP-LND option is also provided, and like I mentioned, all three options are associated with greater than 99% disease-specific survival. Offer adjuvant chemotherapy with one course of BEP again, or surveillance, and discuss the advantages and disadvantages. Offer surveillance to the patient not willing to undergo adjuvant chemotherapy. Offer not sparing retroperitoneal lymph node dissection to highly selected patients only, those with contraindication to adjuvant chemotherapy and unwilling to accept surveillance. Primary RP-LND should be advised in men with post-pubertal teratoma with somatic malignant component, which I have already explained. Now, study favoring active surveillance. There was a British Columbia Cancer Agency and Oregon Testis Cancer Program study, which included 209 men with high-risk clinical stage 1 disease. 60 of them had lymphovascular invasion, 109 had embryonal carcinoma component on their pathological examination, and 40 were associated with both. The median follow-up was of 4 years, and in all of these cohorts, disease-specific survival was 100%. The relapse rate was 55% for men with lymphovascular invasion and embryonal carcinoma component predominant tumors, 50% in case of lymphovascular invasion only tumor, and less than 20% for men with embryonal carcinoma predominant tumor. Now, only 8% required post-chemotherapy resection of residual masses in this study. Now, data to support the use of adjuvant chemotherapy. There was German testicular cancer study group. Men with clinical stage 1 non-seminomatous germ cell tumor were randomly assigned to treatment with one cycle of BEP or RP-LND. The median follow-up was 4.7 years. So there were only 2 relapses and no cancer-related death among 191 men treated with BEP. Study reported a significantly lower rate of recurrence with BEP compared with RP-LND, 2 versus 15 events. An improvement in 2-year recurrence-free survival rate with BEP, and cancer-specific survival was 100% in both arms. So in some stage 1 tumor, in most stage 1 tumor, one cycle of BEP was recommended, but 2 cycle of BEP was also recommended, especially in case of stage 2 disease or a patient with T3 or T4 tumor, due to the limited data on outcomes for these cure rates. Now in most cases, 1 cycle of BEP was recommended because with either of the approach, disease specific survival was over 99%, so there was no use of giving 2 cycles of BEP, especially for low risk disease. So retroperitoneal lymph node dissection is a safe in experienced hands and essentially no mortality and extremely low rate of ejaculatory dysfunction or other long-term morbidity. Substantially reduces the number of men who ultimately receive chemotherapy, and like it was explained in previous presentation, paracaval lymph node dissection is mostly advised in case of right-sided testicular cancer and para-aortic in left, because it's commonly spread to those areas, but not in all the cases. Similarly, the boundary includes, in a case of right side testicular tumor, the medial boundary is the center of the aorta, and lateral boundary is the ureter, and the superior margin is the hilum of the kidney. Similarly, in case of left testicular tumor, the medial boundary is the center of the vena cava, ureter on the lateral side, and the hilum of the kidney on the superior side. Now, stage 2 disease. The first year, so
second year.
So patients are advised to follow up at least 4 times in first year with measurement of their tumor markers 4 times. A chest X-ray is done twice yearly, and CT abdomen and pelvis is done twice yearly in case of low risk disease, and in case of advanced disease, CT CAP is done twice yearly in year 1. So but this is going to come in like following slides, sir.
Okay.
We have Dr. Mudassir today with us. I would like to express my gratitude on behalf of all the residents to him, and also wish him all the best for his future, and thank you, sir. Now, stage 2 disease. Stages 2B and 3C are straightforward to diagnose clinically, but the accurate diagnosis of stage 2A is more complicated. Now, this is because a significant number of men with mild adenopathy, which was previously thought to be clinical stage 2A disease, will be found to have benign nodes, that pathological stage 1 if RP-LND is performed. And similarly, in a significant number of men with normal sized retroperitoneal node, that clinical stage 1, will have cancer discovered if RP-LND is performed. But this is not something which is usually done, because in clinical stage 1, we do not go for RP-LND in most cases. So CT scans have substantial false negative and false positive rates. The serum tumor markers must be within S0 to S1 level, that is LDH should be less than 1.5 times the upper normal limit. In some cases, cutoff is also taken as 3 times the upper normal limit, because LDH is not very specific to testicular tumor. It is also seen increase in any ischemic heart disease, liver disease, muscular disease, etc. So alpha fetoprotein levels should be less than 1000 nanogram per ml, and beta HCG less than 5000 milli-international units per ml. If S2 or S3 level is found, then they are considered to be stage 3 disease, even if there is no metastasis beyond retroperitoneal nodes. So treatment, the clinical stage 2 non-seminomatous germ cell tumor have a high likelihood of cure, and approach depends upon the size and imaging characteristics of retroperitoneal lymph nodes and the serum tumor markers obtained post orchiectomy. If there is normal tumor markers, that is S0 in stage 2 tumor, then clinical stage 2A for men with lymph node less than 2 centimeter, RP-LND rather than chemotherapy is preferred. RP-LND provides more accurate staging and cures 80 to 90% of the men with stage 2A nodal disease. Alternatively, for those patients who do not wish to proceed RP-LND, chemotherapy with 3 cycles of BEP or 4 cycles of etoposide or cisplatin alone is given. But for residual adenopathy, even after the completion of chemotherapy, post-chemotherapy RP-LND should be performed, especially when the residual nodes is more than 1 centimeter. Now, surveillance. Now, surveillance is provided in ambiguous conditions, again, clinical stage 1 versus 2A disease. Lymph node less than 2 centimeter of the greatest diameter or non-nodular shape. Early reevaluation at 6 weeks is advised to the patient. The goal is to avoid overtreatment. Now, why do we go for surveillance? Is to avoid overtreatment in case of benign mild adenopathy in minority of the men, and even with surveillance, the prognosis is excellent. In case of progression, cure is still attainable with chemotherapy or in selected cases retroperitoneal lymph node dissection. Now, for clinical stage 2B to 2C disease with men with retroperitoneal nodes more than 2 cm but still S0 tumor markers, chemotherapy is preferred over RPLND. Now, earlier, this is because chemotherapy provides earlier treatment of micrometastatic disease and spares men from the morbidity of RPLND. Regimen is again 3 cycles of BEP with alternatively 4 cycles of chemotherapy. Again, even after we go for RPLND, even after we go for chemotherapy, if there is residual masses, we go for RPLND. So there was non-randomized comparison of primary chemotherapy versus RPLND for clinical stage 2A and 2B non-seminomatous germ cell tumor. And primary chemotherapy was associated with improved relapse-free survival compared with RPLND, 98 to 79% with significant p-value, but disease-specific survival did not differ significantly. So chemotherapy results in similar survival outcomes compared with RPLND in stage 2A disease, but is thought to be probably superior for men with stage 2B or 2C disease. Okay, now stage 2 disease with elevated tumor markers, that is S1 level. In all stage 2 disease, 2A to 2C, with mild increase in serum beta-HCG or alpha-fetoprotein after orchiectomy, we go for chemotherapy. Now, goal is to again prevent distant metastasis. Even after chemotherapy, if the residual mass is more than 1 cm, we go for RPLND. The post-chemotherapy residual mass less than 1 cm, we opt for surveillance. So there may be excess risk of recurrence in absence of systemic therapy, which was shown in the study in which there was 95 men with pathological stage 2 germ cell tumor. RPLND followed by observation was associated with a recurrence rate of 51%. And in cases where there was increased beta-HCG, recurrence was 55%. With elevated alpha-fetoprotein, relapse rate was 56%. In case of increase of both tumor markers, relapse rate was 59%. And surveillance in men with residual mass less than 1 cm came from is also supported by a meta-analysis which was done in 2014. It included a total of 10 studies, 6 studies with post-chemotherapy RPLND and 4 surveillance studies. In surveillance study, disease occurred only in 5% of the cases, whereas RPLND was following RPLND there was some complications which was obviously not seen in surveillance group. So pathological stage 2 non-seminomatous germ cell tumor treatment, now it's based on pathological finding within the retroperitoneal nodes retrieve. If the men with pure teratoma was seen in retroperitoneal nodes, again we do not see any benefit from adjuvant chemotherapy, or so we opt for active surveillance after RPLND. Men with tumors containing elements of embryonal carcinoma, seminoma, yolk sac tumor, or choriocarcinoma, either adjuvant chemotherapy or careful surveillance is advised. If there is recurrence following surveillance, then systemic chemotherapy is advised. So, in case of patients who have undergone retroperitoneal lymph node dissection, that is, and then diagnosed as pathological stage 2A disease, again active surveillance is advised rather than chemotherapy. In stage 2B or 2C pathologic disease, adjuvant chemotherapy following RPLND should be advised with 2 cycles of EP or BEP. So general approach to advanced disease, specifically stage 3 disease. Now, advanced or disseminated testicular cancer includes metastasis to retroperitoneal lymph nodes or beyond. In most cases, either stage 3 or even stage 2B or 3C is considered as advanced testicular germ cell tumor. So men with abnormal tumor markers alone are treated the same as stage 3 because of risk of occult metastasis. Now, patient with primary mediastinal or retroperitoneal germ cell tumor, even in the absence of metastatic lesions. Okay, now the stage or advanced germ cell tumor are divided into good prognosis group, intermediate prognosis group, and poor prognosis group. In case of non-seminoma, with a good prognosis group has a 5-year progression-free survival of 90% and 5-year survival of 96%. It includes all of the criteria like testis and retroperitoneal primary, no non-pulmonary visceral metastasis, and all tumor markers at S1 level, up to S1 level. Intermediate prognosis group in non-seminomatous germ cell tumor, the 5-year progression-free survival was 78%, 5-year survival is 89%, and the criteria is testis and retroperitoneal primary with no non-pulmonary visceral metastasis, and all tumor markers within S2 level. In poor prognosis group, any of the following criteria fall under non-seminomatous tumor with mediastinal primary, non-pulmonary visceral metastasis, and serum tumor markers at S3 level. They have 5-year progression-free survival of 54% and overall survival, or 5-year survival of 67%. So in case of a good risk group, the cisplatin-based combination therapy is recommended. And now BEP rather than EP in most of the cases, although both regimens are acceptable. For men with increased risk of pulmonary toxicity from bleomycin or age more than 50 years, EP is preferred in most cases. Now, if BEP is used, 3 cycles is given, and EP again 4 cycles. So BEP as first-line therapy. There was URTC trial, 395 men who were randomly assigned into treatment using 4 cycles of EP with or without bleomycin. Compared with BEP, BEP resulted in a significantly higher complete response rate, 95% with BEP versus 87% of EP. Fewer death was associated with 4 cycles of BEP, 3% versus 6% following EP only. Significantly higher rates of pulmonary toxicity and neurotoxicity was seen with BEP in BEP group, including 2 deaths from pulmonary toxicity. Now, in case of intermediate and poor risk group, 4 cycles of BEP rather than other platinum-based regimens is recommended. In case where bleomycin is not used, ifosfamide, etoposide, and cisplatin is an alternative. Now, cases where BEP is not used includes underlying lung disease, now bulky lung metastasis which may require post-chemotherapy resection later on, extensive tumor burden in the lungs, and men with primary mediastinal non-seminomatous germ cell tumor who typically undergo post-chemotherapy resection of residual mediastinal disease and are thus risk of perioperative bleomycin-related lung toxicity. Now, ifosfamide, etoposide, and cisplatin can also be used as alternative to BEP. Now, this comes from a trial. 299 men with poor risk disease were randomly assigned to 4 cycles of either BEP or VIP, and median follow-up was 7.3 years. And there was similar rate of progression-free survival, 58 versus 64%, and overall survival 67 to 69% with BEP and VIP group respectively. Now, this slide shows the use of chemotherapy in various good risk, intermediate risk, and poor risk groups among advanced germ cell tumor, in which in good risk group 3 cycles of BEP or 4 cycles of EP is advised, and intermediate and poor risk group 4 cycles of BEP or 4 cycles of VIP is advised. Now, this has already been explained in previous slides. Now, surveillance. Now, so how do we monitor the response to the treatment in the patient following their specific treatment? Now, for minimal follow-up for non-seminomatous clinical stage 1 on active surveillance, in year 1, 4 times the doctor visit and tumor markers are measured. Chest X-ray is performed 2 times in year 1, and CT, abdomen and pelvis 2 times in first year. Similarly, in year 2, 4 times the patient is again advised to check their serum tumor markers 4 times with X-ray twice, and CT, abdomen and pelvis once at 24 months. In year 3, again, tumor markers is measured twice with chest X-ray once, especially in case of lymphovascular invasion, and CT, abdomen, pelvis at 36 months. In year 4 and 5, tumor markers is measured 1 to 2 times, and X-ray at once at 60 months, and again abdomen, CT, abdomen, and pelvis at 60 months. The recommended minimal follow-up after adjuvant treatment or complete remission for advanced disease. In year 1, again, it's similar to clinical stage 1 on active surveillance, but it includes thoracic CT. Similarly, in year 2, 4 times tumor marker is measured with X-ray once, and abdominal pelvic CT-CAP actually at 24 months. In year 3, tumor marker is measured twice, X-ray is performed once, but again CT-CAP once at 36 months. And in tumor markers in year 4 and 5 is measured twice with CT-CAP once at 60 months. Now, with the recent advances in all the treatment approach, in case of non-seminomatous germ cell tumor, there is excellent survival outcomes. Especially, this has been seen in patients with poor risk disease. So there was multinational observational study which included 5,202 patients in non-seminomatous germ cell tumor. Approximately 56% of them had good risk disease and remaining 44% as intermediate and poor risk disease. Now, 5-year survival, progression-free survival and overall survival rates for these patients were 89% in good risk group and 92%. In all the patients were 89% and 92% respectively, the progression-free survival and overall survival. Among the approximately 28% of men with non-seminomatous germ cell tumor and intermediate risk group, the 5-year progression-free survival and overall survival were 75 and 80% respectively. And especially in case of poor risk group, which included which were 16% of the total study group, 5-year progression-free survival was 41% and overall survival was 48%. The similar result was seen in another meta-analysis, which included 10 studies on the subject were 1,775. 5-year overall survival 94% for good risk, 83% of intermediate risk, and 71% for poor risk disease. Now this is the summary of my today's presentation. Thank you.